So, Laurie, today is my turn to do the introduction. We jumped into this podcast a little bit head over heels, I think.
Yep.
We've had 2 episodes. We've managed to change our name. We've been learning at a brisk pace as we went along. So,
Yeah.
so welcome to our 3rd episode. And as some of our listeners might have noticed, we've decided to change the name.
Yes, and I love the name. We've decided to go from conversations around breast cancer to decoding breast cancer. And the reason?
It's a little bit like when I was little, I used to take things apart. My mom was very frustrated by me always having electronic equipment being taken apart because I wanted to understand how they work. I suppose that's why I'm a surgeon. I still like taking things apart. So, yeah, I think people are perplexed by this topic and they are sometimes overwhelmed, and it can be a very cold and stark thing to talk about. So I think part of this is really deconstructing it and looking at the little parts that makes breast cancer what it is. And actually there's so many interesting things about it that we can do a whole series about that.
Yeah, I think for me, being the patient, I had many questions. And I think when you're in the situation, you often don't ask the questions because you're scared. And then when you go through your treatment, you forget to ask the questions. And then when you've gone through this, then you don't want to know the questions or the answers to the questions anymore. So I am very excited to be able to have somebody like you so knowledgeable about the whole topic around breast cancer to give us those answers that we are too scared to Google or to find the answers to. So, Dr. Etienne, I want to know, tell us a bit about yourselves. You're a surgeon, but why are you an oncology surgeon?
Yeah, I always tell people that I knew that I had to be a doctor from a very young age, probably about 5 or 6. And I've always been an inquisitive young boy. I remember I was fascinated by Etienne Myburgh's book on termites, for example, and my grandmother had to read that to me, and I wanted to understand how things work. So, and my grandfather had to be hospitalized in Pretoria, and those days the best expertise was all still sort of in the academic hospitals. And I convinced all the nurses there, they would keep all the drip bottles and the drip lines and the needles and whatever. I went home every time we went to visit. I went home with packets full of medical stuff. These days, people would get into trouble if they sent all those disposable items away. But anyway, and I remember I made a rag doll that I then implanted a little jiffy bag into this doll's chest with a little pipe going up to the mouth that I could do mouth to mouth. And I would put a little bottle inside the belly of this doll with a little line going to the arm so I can put up a drip. So, yeah, I was fascinated by medicine. When I was at school, I could wait if there was a gap to go and help at a veterinary practice or anything like that. I would be there. I just knew this was purpose. This is what I was born to do. And my teachers would say, yeah, but your marks are not good enough. You'll never get into medical school. And in my mind, it was, I think these days everybody knows about hulle weet nie wat ons weet nie. They don't know what we know. But I think I coined that term back in, Standard 7 in 1980 something, So yeah, I went to med school, did medicine, enjoyed every bit of it. It's one of those things like this is, you just can't get enough of it. Probably knew I had to do surgery in about my 3rd or 4th year. And then at that time, surgery was quite a difficult specialty to get into. I think it's before people got lazy and wanted to do nice cushy jobs like being radiologists and dermatologists and ophthalmologists and, things that you don't get called at 12 o'clock at night. And anyway, so if you wanted to do surgery, you had to go and work in a hospital where you would get some hands-on experience. I went to, in those days it was still called Petersburg. These days it's Polokwane. That was a big secondary hospital that drained most of the northern part of the country, had lots of trauma, lots of surgical patients. And there I was in the fortunate position to be guided by some really good mentors. And as I grew as a young surgeon, they appointed more senior people at that same time. So I was able to then grow some of my skills. In the end, got phoned from Cape Town to say, we're looking for someone that has some experience. Would you want to come and work here? And then decided, well, why not? Came down to Cape Town, finished my specialization here. And as you're training, you are rotating through trauma surgery and abdominal surgery and burn wounds. And I think the cancer part, the unit we worked in, was called the head, neck and breast unit. So those days there was a concept that you were a head, neck and breast surgeon where you did head and neck cancers and breast cancer, some sarcomas, things like melanomas. And Tygerberg had a very good unit at that stage. And I think my idea was that I would really just, become a head and neck surgeon. But because of this breast surgery that was part of it, then in the time that I was finished specializing and being a consultant in oncology surgery, the whole field of oncoplastic breast surgery started being developed, which brought into breast surgery this element of reconstruction. So the days of just doing a mastectomy and an axillary dissection was becoming extinct. I wish it had been extinct a long time ago, but anyway. And that brought a new facet into cancer surgery, breast cancer surgery, that I enjoyed. In the end, when I went into full-time private practice, I continued to be a head and neck oncology surgeon as well as a breast surgery. And that would be about 50% of my work. And, I knew that the long-term future of cancer surgery really is being part of a team of people that looks after this person. So I always contended with the hospital to give me bigger rooms and bigger space. And every time they said, but what do you want? And I said, I want to have a wing of this hospital because I want my cancer patient to walk in one door and be helped in all their needs in one physical space. Then in 2019, actually, the Mediclinic that I worked in, the regional managers came to speak to me and said, but we want to hear about this. And in the end, we then started this concept of the Panorama Center for Surgical Oncology. And the idea was very much exactly that it would be one physical space where the surgeon and the plastic surgeon and the geneticist and the oncologist and the psychologist and the rehab and everything would be in one physical space, and where the patient can come in at one door and be helped, and that there would be complete transparency, one note system, continuity of decision making. And we started there the 1st of February 2020, exactly 6 weeks before COVID lockdown started. And I had all these colleagues that were complaining about how they lost all their income and they were not working. And we were like, well, fortunately, cancer is a condition that can't wait another how many months. So our work just grew. And since then, we've just had, exponential growth every year. So, that's me. So I think at the moment, I am the senior surgeon in the unit, and we are fortunate, I think, to be actually the only unit where we are working cohesively as a single entity towards helping our patients. And I think for me, that's a huge privilege.
I agree with that, because I think as a patient, I obviously, when I was diagnosed, you guys didn't have your unit. You have to see this doctor in this room, in this hospital. Then you need to go there to have that done with another person. So you tend to have to run around between this doctor and the other one, between different hospitals. And I think Paxo has definitely become, it's like a one-stop shop where you can come with your breast cancer, if I can make it as light as that. But and also you guys all talk with one another and to each other. So one person gets covered. You discuss, every patient is covered with all the other doctors. So everybody knows about your condition or what you're going through. So it's not like, you walk in and nobody knows who you are. The plastic surgeon, you talk to the plastic surgeon, then you talk to the oncologist. And I think that for me makes it, as a patient, it calms you, especially in this time when you are completely overwhelmed with what's happening with you. So tell me, Dr. Etienne, what do you do for fun? Do you have hobbies?
Lots of things. Well, I do podcasts.
Yes, in your free time.
No, I enjoy the outdoors. We try and go hiking up Table Mountain at least 2 or 3 weekends a month. So I enjoy being out hiking, camping, fishing. I have a boat that I take out to Witstrand. I actually enjoy computer programming and developing little AI agents to help with research and stuff like that. I enjoy woodworking and doing physical things with my hands, building things. I play music, recorded music. I did acting. I wrote stage productions and helped direct them. So yeah, I think I enjoyed my life. So,
yeah, you're well-rounded in all areas.
yeah.
And the last thing I want to know, so I know we're doing this. What is your aim with this podcast series, and why are we doing it from your perspective?
I've said many times that I can help one person at a time with a scalpel in my hand. But if I can influence the way that people access care, that people are cared for, that people know about what they can do and should have access to, then I can help a lot more people than just one person lying on a theater table in front of me. So I spend a lot of time in education, trying to upskill doctors and colleagues in terms of proper care for breast cancer. I spend a lot of time in awareness amongst patients about what they should be able to access. So this podcast is part of that. It's aimed at people that maybe don't have breast cancer, or people that know someone that has breast cancer, or people that are recently diagnosed with breast cancer, to try and educate them in terms of what they should and shouldn't be concerned about, what they should see as the standard of care that they should have access to, and that those people can become advocates for healthcare for other people. So I think that's the purpose for me of spending hours of my time trying to do podcasts like this.
Yeah, and it's not like you're busy enough during the week. He does this between 2 and 4 in the morning, I think. Because I think I got an SMS or WhatsApp last night at about 11:30. I was also still awake. And I'm thinking he starts at 7. What time do you start your rounds?
Yeah, normally I leave at about 6:30, so
Yeah.
I start my day at about 7.
Exactly. So then between 2 and 4 in the morning, he does this.
Anyway, so no, I think this is a labor of love for me, and because I think people deserve better care.
Yeah. Well, if I think back of in 2018 when I got that mammogram that wasn't great, and you and my husband being colleagues, and you squeezing me into a lunchtime session, looking at my mammogram saying this is not looking good, and we're doing a biopsy immediately. I think that's the first day, obviously, that I met you. And that's the first day that I realized, sure, this man actually cares about his patients, because the way you explain things to people, and if we don't understand, you'll even draw a picture. So I think when you are a patient in your practice, people are well equipped and well knowledgeable about what's going on. So I immediately thought, I like all these answers that you gave me, and I can become very inquisitive when it is something close to my heart. Now, obviously, I had stage 4 HER2 positive breast cancer. They never even knew what it meant. But the way you explained it to me, everything gave me a sense of, you know what, I want to know more. And as I went through my treatment and got out on the other side, and 7 years later, I think I'm now an ambassador for breast cancer, but I've given the title to myself. I've made an effort. So through my social media, I've also felt that I needed to not equip women, but allow them to be authentic and real and not fake this whole thing, because speaking to a lot of women, they want to try and be so positive, and then when nobody's around, they fall apart. So I want people to know the facts, but also be there to understand the emotions and to be authentic and to be real. If you want to cry, you cry, and if you want to laugh, you laugh. So I remember in the beginning of the year, we had that survivorship day at Dr. Etienne's practice, and we had some keynote speakers there, and we had breakaway groups. And I remember before that, I wanted to actually send you a WhatsApp and ask you, what do you think about us doing podcasts? Because we have done a few YouTube videos, if you guys are interested to watch them. And then he said yes. And then nothing happened. And then with my 6-month follow-up, he asked me, so what happened to that whole discussion we had about the podcast? So that's when we decided to put a date down and start. And here we are.
It's the same with lots of things. Lots of people have good ideas, but the follow-through is where things often lack. So Laurie obviously is a patient of mine. I've been privileged enough to have her entrust her journey with me, the part of it that I'm involved with. You've already now told us that you were diagnosed with stage 4 breast cancer. Obviously, the day you walked into my office, we didn't know that. We just knew that something was up and we did the biopsy. So maybe tell our listeners a little bit your journey from that initial diagnosis and then treatments you had and things like that.
Yeah, I think after I did the biopsy, I got the news the next day it's cancer. The day after that, they told me it's HER2 positive. And then the week after that, I had all my tests. There's always tests, CT scans, bone, what do you call it?
Bone scan.
Yeah, bone scan to see if it's metastasized to your bones. And on my CT scan, they saw some things in my liver. And the radiologist was trying to play it down and said to me, no, maybe it's hemangiomas, let's do a PET scan. So I did a PET scan, and I remember sitting in the cafeteria and my husband coming to me and telling me, but okay, so no, it's not hemangiomas. It's definitely metastases. And I think, sure, even though it was hard to hear I've got cancer, finding out it was stage 4 was hard for me because I lost both my parents to cancers at stage 4, and they, with treatment, only lived for 10 months. So immediately I thought that was going to be my last Christmas because I was diagnosed in October. Really, really hard. Then I started chemotherapy. I had 4 Red Devils every 3 weeks. Then I had 12 paclitaxels weekly. And after I finished my chemotherapy, we did a scan, and on the scan we saw that the nodules in my liver has changed, and also if you felt the breast lump, that also disappeared. And then Dr. Etienne decided to continue with a mastectomy, and I had a double mastectomy where we did reconstruction with silicone. Unfortunately, then I went on holiday to London with my fancy new reconstructed breasts and had complications. Somehow the wound didn't want to heal. I think you said you think a biofilm might have formed around the silicone and it prevented the wound from healing. So I'm overseas with tape. I'm typing this thing, and as soon as I landed that Monday afternoon at 11 o'clock, I was in theatre at 2 p.m. So we could remove the silicone on the left side. Then I had radiation. I had 16 radiations. It's a daily thing that you have to do. So I must say it's something that tires you out. Then after a while, COVID came around, and I had a really swollen breast, the one with the silicone. I went to see the plastic surgeon, and she said, no, she thinks it needs to come out. So when she tested me for COVID, I had COVID, so now I had to wait for that to disappear. Had it removed. And after that, I was on Herceptin, which is something that I get every 3 weeks, targeted therapy. And as a stage 4 patient, Dr. Etienne told me I've got to be on it for the rest of my life. So for 80 of those 4.5 years, I got Herceptin every 3 weeks, which I think is hard because every time you walk into the chemotherapy room, you're reminded of, okay, you are a breast cancer patient. Then I asked my husband to give it to me, and then he started giving it to me. So now I am down the road 7 years and still cancer free. Still have to go for regular checkups. I've been going every 6 months, and hopefully we'll be able to change it to every year, which I'm a bit nervous about. But during this time, I lost my hair, obviously like any other breast cancer patient, and started to make my own hats because I had a bit of home economic skills, standard 6 and 7. And that really helped me to focus on something other than just the disease and what I'm going through. Now I have an online business, and just being vulnerable and talking to people and being authentic and sharing my story with other people has now given me a sustainable business online, which I love doing, and I get into contact with a lot of women. I am there if they need to speak to me. I know people might think this is crazy, but to speak to somebody who has gone through it, I think reassures you that you're going to be okay. Even though I think you know you're okay, but it's just nice to speak to someone and listen to what they went through, and that what you are going through is normal and it's okay, and that you won't, nothing will happen to you, but just be open and share your story.
Yeah, thanks, Laurie. I think that it's always an inspirational story to listen to this whole journey. because it wasn't this fairy tale story of everything just went well. There were little hiccups in between. The news in the beginning wasn't great. And I think what people maybe don't understand or realize is that in principle, almost all cancers, if you have metastatic cancer, it is considered incurable. So in 1995 or 1999, if you had breast cancer that was metastatic, there would be zero chance of you surviving breast cancer. Now, some patients could live for many years with metastatic breast cancer, but we would have no patients that would be considered cured of breast cancer. So when Herceptin came along, trastuzumab is a targeted treatment towards HER2 positive breast cancer, which is what you had. So it's a very specific subtype of breast cancer. And that combination of chemotherapy with the targeted anti-HER2 treatment gave us the potential of actually curing a metastatic breast cancer patient. And I still remember the first patient that I had probably back in about 2003 or 4 that came to me with her whole breast, the whole chest was full of cancer. Her lungs were completely filled with cancer. And she was one of the first patients that we started treating in this regimen. And after a while, the lung nodules were gone and the breast was looking a lot better. And then you're like, okay, wait a minute, what do we do now? And then you would wait, and later on we said, well, maybe we should do surgery for her, and you would do surgery. And then even later it was, okay, you're now on this medication for 15 years of your life. So, maybe we should at some stage make this decision that actually you're cured. So when you came along, we have had a few of those patients in the past. And I think it is still a little miracle that one could have an incurable disease that with the right treatment at the right time, there's still this chance for cure. So yeah, that is the amazing thing. And then the difficult part for us as a doctor comes in that you at some stage have to have the discussion about, should we now stop this medication? And that this was a difficult discussion, because in the one end you feel like, okay, this is my little safety blanket, if I let go of this, then what's going to happen? So there comes this element of trust. Then I have to say, there is this chance that my cancer will come back, whether I continue with the medication or not. I think in the previous podcast I said we want to assign, it's your fault or it's this thing's fault that something happens. But frequently you get to a point where you'll say, well, we've gotten the benefit of this as much as we can, but continuing with it is not going to add more benefit. So yeah, that's a great story. And I know that you are someone that encourages a lot of women on their journey with breast cancer. So you're making a big impact in this world. So that's great.
Yeah, as I say, you don't go through this and not talk about it. So hopefully everybody out there now knows who Dr. Etienne is and who I am. And now we will continue with the rest of our series in our next podcast. Thank you.
Yeah, thanks, Laurie. We'll chat again soon.
Absolutely.